talk on the social value of trauma systems is not only the injured who benefits. Dr. Russel Gruen is a Dean of the Australian National University College of Health and Medicine, Canberra. He's a former trauma surgeon from the Alfred Melbourne, Professor of Surgery and Public Health, Monash University, Director, National Trauma Research Institute, established the Australian Trauma Quality Improvement Program and the Australian Trauma Registry and the Australia-India Trauma System Collaboration. He's also the author of the Victorian State Trauma System and the president of the Alliance for Surgery and Anesthesia Presence, the global surgery arm of ISS. Colleagues, let us now welcome Dr. Russel Gruen.
Thank you very, very much, Dr. Joseph, and it's a real pleasure and honor to be with all of my colleagues here today. I've known many of you very well for many years, and I think some truncating of the words in the introductory slide gives me more credit than I was due. I've written a book on the Victorian State Trauma System, but certainly wasn't an author of the system. And there are many people who have collaborated with me on building and bringing to fruition the Australian Trauma Registry and the Australia-India Trauma Systems Collaboration, who are great friends and colleagues and who I admire enormously, and some of them are here today. So there was an advertisement, it was sort of an advertisement, it's sort of a fundraising thing on the television about 10 years ago in Victoria, which was a commercial that had lights and sirens, this sort of road scene, crash, smoke, and an ambulance arriving and people being dragged out of the wreckage of a car, put into an ambulance with all the noise and the smoke, and then rolled into the hospital on a gurney like this. And it finishes with the nurse leaning over and saying, "Don't worry, you're at the Alfred." Now, many people know the Alfred, and the Alfred could be one of any major trauma hospitals around the world. The point of the ad was not as a message to people about injury or prevention of injury or drive safely, as so many of the previous commercials were. The ad was conveying to the whole population that you're lucky you've got a system that looks after injured people, and don't worry, if the worst happens to you, there'll be someone there to support you. So I'm just going to stop sharing my screen for a minute and go back to the idea that actually trauma systems have played a major role in advancing well-being throughout the world. And it might seem a surprising topic. Of course, trauma care is there to serve the injured, but I think actually I'm going to make a case that they do more than that. Trauma systems are primarily for the injured, but their designation reassures the community that help will be there and will be provided if it's needed. And by being there, they promote the well-being for all. And in doing so, trauma systems are in fact a model system by which civilized societies protect their citizens from harm and care for them when they're harmed. Governments do other things to protect their citizens. They defend against invasion, they maintain law and order, they regulate products and environments, they enforce transport and workplace safety, and of course they provide emergency services and healthcare and social services. And because they do these things, citizens in societies can flourish and realise their full potential. Many of you will remember Maslow's famous hierarchy of needs. Personal safety needs are prerequisite for all other forms of fulfilment. And everyone's talking about well-being now, and we think about well-being broadly defined as something like the state of being comfortable, healthy, or happy at more than one moment in time, relating to people's satisfaction with their life as a whole, their sense of purpose and how in control they feel. Clearly, well-being has a lot to do and is intimately tied to personal safety. So having focused a lot on trauma systems and their role and their development in societies, I think we can use trauma systems to look at how governments can advance the safety of their citizens. But we need an organised story to be able to do that. And that's what I'd like to touch on a bit today. So firstly, I don't think many of us need too much background on what a trauma system is, but let's just say it's a coordinated approach to injury prevention and post-crash response, and to the management of not just the patients, but the management of the system as being the key components. So instead of an isolated specialist hospital, we're talking about a trauma system being an organised, coordinated effort in a whole defined geographic area that involves multiple agencies, is integrated with the local public health system, promotes injury prevention, and delivers the full range of care to all injured patients through pre-hospital, hospital and rehabilitation services. And high-performing trauma systems have mechanisms to ensure good governance, accountability to their funders and the providers and the communities they serve, and are underpinned by robust monitoring and incentives for systems improvement. Sophisticated registries enable precise definition and collection and reporting and analysis of data about who is injured, the circumstances in which they're injured, what injuries they sustained and how they were treated and their outcomes. And there's a lot of evidence now about trauma system effectiveness. One of the best studied is one that many of you will be familiar with, and I'll spend a couple of minutes talking about Victoria because I know it well, and I'm a great admirer of the Victorian state trauma system. In 1969, Victoria had a population of about 4 million and over 1,000 people killed in road traffic crashes, which made it the jurisdiction in the world at the time with the highest per capita rate of road deaths. There was speed, alcohol, all sorts of risk-taking behaviours were rife, especially amongst young males, and there was little attention to safety paid in vehicle and road design. And carnage just ensued, killing vehicle occupants, pedestrians and cyclists. In 50 years, so it's a long time, but it's 5 full decades, this situation has been completely turned around. And it's been through successful health and public policy interventions. And the per capita death rate cut by more than 85%. And Victoria now taking seriously the idea that road traffic fatalities might be able to be eliminated altogether. Now, this achievement was the product of innovative and sustained approaches to preventing injury, saving lives and optimising recovery. Beginning with the world's first compulsory seatbelt legislation in 1970, the Victorian government repeatedly introduced progressive road safety legislation, standards for road vehicles, road design, licensing, regulatory changes, all those things. And the introduction and policing of road safety laws all contributed to reducing the road toll. That's all prevention type activities. But over this period too, there were 3 really pivotal things that led to the development of a new system of care. The first was a public awareness campaign sustained over decades on the roadside, in sporting events, in the newspapers, in the classrooms, on television in people's living rooms, where dramatic commercials like those images I showed you at the start are smashed and people broken and smashed up, and then big slogans like "drink drive, you're a bloody idiot," or "speed kills," meant that Victorians, a whole generation, my whole generation of people, were sensitised to injury being a major public policy concern. And we were willing, therefore, to give up perhaps other freedoms to ensure that people were safer on the roads. The second major change was a financing system that it could afford to provide insurance for everybody who was involved in a motor vehicle crash, through attacks on their vehicle registration that led to assurance that they would receive the care they needed, irrespective of whether they were able to pay up front and out of pocket for the care. And so it bankrolled the ability to make system changes that were agnostic about wealth, status, in fact, whether people were drunk or whether they'd stolen the car or whether they were speeding or otherwise breaking the law, everybody got treated the same. And doctors were incentivized to be part of that system. So a financing system was the second key element. And then the third key element was the spark that ignited a fire. And it was the idea of preventable deaths. Throughout the 1990s, a team of people in Victoria reviewed every road death. They come together once a month, sit around pizza boxes and go through the notes of every person that had died on the roads, looking for opportunities for that care to have been improved and making a decision as to whether it was preventable, potentially preventable or non-preventable. They determined that 30% roughly of all road deaths were preventable or potentially preventable, and that over the course of that decade, that didn't change at all. And there was proof that the system was failing the community. People always thought that there'd be bad luck and young males would drive too fast and get drunk and kill themselves. And they could kind of come to terms with that. But the public couldn't come to terms with the idea that people were dying because their healthcare wasn't good enough. And it led to, in 2001, 33 years after the peak of the road toll in Victoria, the implementation of a new system of care, the Victorian State Trauma System. Now, I want to tell you what happens in that system just to take you through, and maybe you can compare it to what your own system does. This system was built by all the people across the state who had many contacts around the world, around the region, particularly on the west coast of the United States at the time, where a lot of innovation was happening in trauma system development. And it was conducted by a ministerial review, where they actually had a formal process to look at the way things were, look at what was happening overseas, decide on an optimal arrangement, and made almost 200 recommendations that really transformed the healthcare system for injured people. So let's just go through that just briefly for a minute. And I'll describe sort of what happens to a patient. So from the moment of injury, a single statewide emergency number and triage and transfer protocols ensure that each case has the appropriate degree of urgency based on standard criteria. And when these criteria are met for major trauma, on-scene ambulance paramedics liaise directly with a specialised statewide advisory and retrieval service that coordinates the clinical needs of that patient and the logistics of the retrieval, whether it be by road or in Victoria, quite often it's by helicopter because it's relatively small. And helicopters can go directly to the roadside and in one foul swoop, quite often land on the helipad of the receiving trauma service, bypassing therefore non-specialist hospitals. Pre-hospital care is provided at the scene by highly trained ambulance paramedics using great protocols, excellent communications. They're trained to perform life-saving procedures such as endotracheal intubation, chest decompression, blood transfusions, tranexamic acid for hemorrhage, some other blood products as well, and advanced life support for cardiac arrest. The retrieval service not only directs the transfer, but also facilitates preparations at the receiving hospital by providing critical information to that receiving hospital that enables the emergency department to assemble their team and get equipment ready and operating theatres ready for the patient's arrival if necessary. And it was only at this point that the new statewide trauma system designated 3 major trauma centres, 2 adult ones and 1 children's one, to which almost all seriously injured patients get transported. These high volume services have developed concentrated trauma expertise available 24 hours a day, 7 days a week, with well-rehearsed protocols, experienced specialists in all aspects of resuscitation, surgery, radiology, and critical care, and advanced diagnostic and therapeutic modalities. Following the emergency department care, major trauma patients get admitted to the hospital. The most severely injured go to ICU, of course. They get ICU-based care, one-on-one nursing. Of course, they will need further procedures very often, and organ support, and nutrition, and bowel and bladder and skin care, and so on. And this is obviously also where the family members, who are often coming to terms with the gravity of their loved one's injuries, are also needing a range of supports. From the moment the resuscitation is complete, the recovery process begins, and aiming to restore the patient as far as possible to his or her pre-injured state. So even while in ICU, each patient is assigned a case manager who begins planning the care that will be needed after hospital. Once weaned off the life support, the intensive care no longer required, patients are transferred to the ward, and that case manager really kicks in. Here, ongoing medical and nursing care continues, and often further surgery is still done, but rehabilitation commences on the ward, and sometimes even in the ICU, and involves a range of allied health professionals. So from soon after arrival at hospital, a shared awareness of each patient's particular medical, physical, mental, emotional, and social needs is fostered through collaborative multidisciplinary teams. When the patient no longer needs inpatient hospital care, they're discharged home or to rehab or long-term care facilities, these case managers continue to have significant coordinating roles, helping patients and their families navigate the rehab, medical and allied health specialists, and the social services involved in supporting their ongoing recovery and disability needs. It's a complex system with many moving parts that are coordinated in some ways like a high performing clock. And then there are three other major developments that came with the Victorian State Trauma System that were really important. The Trauma Registry, which was a next generation registry established to guide all aspects of the system by collecting data about all aspects. And until this time, most trauma centres were using dead or alive at the time of hospital discharge as the main outcome measure of trauma care. But the Victorian State Trauma Registry now does standardised 6 months, 12 months, 24 months, 36 months, 48 months interviews of quality of life and health service use measures using trained telephone interviewers, and have really powerful measures of non-mortality survival for long term after the injury. And what that has done is unpack disclose a really significant burden of injury that was previously largely unappreciated because there wasn't the data to demonstrate its existence. So the registry has been absolutely critical, and it's also critical for quality improvement in the system. Secondly, system governance and a state trauma committee with subcommittees, established ways for registry data and case-based data to feed in education progress projects, quality improvement with continual loops cycle of improvement, and direct reporting of the state trauma committee to the Minister of Health. And then the third thing was provider education, and an enhanced provider education network was set up. So there's abundant evidence about how a system like this improves well-being. What do we know? Well, firstly, reduction in mortality. In only a few years after the trauma system was implemented, it had demonstrated that it reduced mortality. The proportion of patients treated at major trauma centres increased dramatically. Many transferred directly from the scene, and the results of those patients were dramatic. In fact, the system within a decade had resulted in halving, more than halving, of the likelihood that any injured patient would die, all other things being equal and staying the same. There are very few interventions in medicine that have been so effective in reducing mortality. And the effectiveness of the system simply on saving lives has been dramatic. But of course, one thing the payers and families reasonably are concerned about is if we're saving people's lives only to have them be long-term, highly dependent, vegetative or near vegetative sort of state people. And so it was refreshing to have these long-term mortality measures and long-term non-mortality measures. And what they demonstrated was, in fact, that everybody's outcomes improved. Fewer people died, but actually also fewer people were left with severe disability and highly dependent. And that was a relief to everybody. Everyone liked that, the payers, the community, the family, and that was a great relief. But of course, what that data also showed was there is a prolonged and underappreciated burden of injury, as I said, especially amongst patients with brain, spinal cord, or major orthopedic injuries. At least a year after trauma, at least 1 in 5 patients hadn't recovered to their pre-injury level of function, hadn't returned to work, weren't even able to live independently, or were still experiencing significant pain. This was really important to actually identify that, recognise that, shifted the focus of the system through those established processes in the State Trauma Committee to move substantially from investing in the upfront resuscitation care and the pre-hospital care to focus more on the needs in the long term of recovery and independence, and help people get through, for those who could fully recover, or to optimise their independence for those who are going to be dependent for a very long period of time. So having that data about non-mortality, quality of life was really important. But I would argue there's even a further step. We've seen the dramatic advertisements, the smash them up, you should be scared if you drive drunk or you drive too fast, that this might happen to you sort of campaign, to a more gentle appreciation that actually everybody is affected by road trauma. And there's been stickers around that have things like touched by the road toll on them, with a recognition that actually a very large part of the number of all of us in the community have in some ways known somebody or been personally affected by road trauma. And then in actual fact, this body of people needs reassurance that when something bad happens, even if it doesn't happen to you, but if it did happen, there is a system there that's going to protect you and it's going to be there for you. And so hence this commercial around that the Alfred was running, which was, I think, mostly a fundraising plan, actually spoke to something very special about what the trauma community has contributed to public society and to good government in civilised societies more broadly. And it's been a very clear demonstration of the ways governments can provide and support the well-being of their citizens by demonstrating that they can do things to protect them in the first instance, and if the worst should happen to them, there'll be a safety net, there'll be something there for them. I don't think we as a community have realised the impact that we've made as a trauma community through building trauma systems and demonstrating that to our people, and it's something that we should be very proud of. Dr. Jones, I'll stop there.